We'll give it just a moment to let everybody into the session, and then we will be getting started here in just a moment. And it looks like our attendees incoming have leveled off, so we'll go ahead and get it kicked off.
Hello and welcome to the next session of the KHIE 2021 eHealth Summit. I'm David Bolt, the CEO of the Kentucky Primary Care Association, and I'm pleased to introduce the next panel session. But first, I need to express KPCA's appreciation to KHIE for working hand in hand with us and recognizing KPCA as a development partner. Our member clinics realize the necessity of using real and timely data as essential infrastructure in helping providers succeed in the value-based approach to healthcare. The support from KHIE is critical to our member clinics as we move forward in implementing our data aggregation platform. It is a mutual partnership to improve the ability of clinics and clinicians to reach targeted value-based goals in cost and quality of healthcare being provided. I need to add Robert, Andrew, and the HIE team understand and are extremely involved in our joint effort to assist clinicians across the Commonwealth. Now it's my honor to introduce the next session of this event entitled The Health C-Suite Panel, Commentary on the Role of IT Quasi Post-Pandemic. The moderator for this session is Robert Putt, the Executive Director of the Office of Health Data and Analytics. The knowledgeable panel is Dr. Brett Oliver, the CIO of Baptist Health, Dr. Judy Thoret, the Medical Director at DMS, Dr. Gary Osenich, Director of Health Informatics at Northern Kentucky University and a longtime co-conspirator, and my dear friend and colleague, Dr. Brent Wright, Associate Dean for Rural Health Innovation at the University of Louisville School of Medicine. I hope you enjoy and learn from this session. Thank you.
I will now turn it over to the panel.
Hello, I'm Robert Putt, and welcome to this session of healthcare leadership to discuss some post and pandemic and federal regs coming down and the effect it will have on our healthcare facilities and providers throughout the Commonwealth. We have on the panel representation from technology, Dr. Oliver is CMIO of Baptist Health, representative from the clinical perspective, Dr. Brett Wright from TJ Sampson in U of L for Rural Health Innovation. From the academic and national representation level, Dr. Gary Osenich, Professor of Informatics and Healthcare at Northern Kentucky University. And of course, from Medicaid, Dr. Terrio, our Medicaid Medical Director. So we have a great group here. I would just say that our objectives are to talk about some of the implications of the federal policy that we heard about in the previous session and what that means to Kentucky healthcare providers, organizations, citizens, to also discuss opportunities for health information technology to support some of these changes going forward, and what are some of the policy implications. And then finally, how can an HIE or KHI in particular help support Kentucky organizations and the citizens going forward? So with the introductions out of the way, I guess we will jump into some of the meat of the discussion. I would just say that with Andrew's opening this morning, I think we could have spent all morning just talking through what has happened, where we're at, what's gone on. It's only been 9 months since we last met. And the amount of things that have come to fruition over these 9 months has been amazing for our HIE here in the Commonwealth. And we appreciate everyone's support, obviously participation of the HIE. and the value that it provides our patients. So let's go ahead and start with some questions if everyone is good. We will start with the first discussion question. This has been a year where we've had several federal policies come about. Two of those have been interoperability and the patient access rules, and they have implications obviously to health IT. The question is, how can we expect Kentucky healthcare facilities to be impacted? And let's start possibly first with interoperability and some of the possible examples and impacts that you have seen. And we'll start first with Dr. Oliver. Comments.
Sure. So I think with interoperability, we've seen a deluge of data. I think there have been some very good things. We're seeing exchange of clinical notes. I just saw a stat yesterday that if back in November or October of last year, if you were exchanging 80% of your notes, you were in the 95th percentile in terms of clinical sharing. If you're sharing 80% of your notes now, you're in the bottom 5%. Just been a huge transition in patients having access to their notes. Patients have always had access to their notes, right? It was just you had to go through an HIM process up to 30 days. Now you're getting it real time. So I think that's been a big change. And as predicted for those organizations and states that were ahead of us in that, it's really been pretty much a non-entity. Now with the interoperability pieces with sharing lab results immediately, that's been a different story. Not that it's been a bad story necessarily, but it's been a different story. That is something that we've not been used to. If I got a pathology report back on a patient, I expected to be able to talk to that patient before they got the results. The government has viewed that as paternalistic and said that's not the way that it should be, and has really made it very clear that even emotional distress is not an excuse to not release that immediately. So that I could see that potential piece of data being revisited, as I've anecdotally heard of some bad outcomes because of that. But in general, I think it's a really good thing. And from a clinical perspective, the patients have enjoyed it. I've not been personally deluged with, oh my gosh, what is this sodium that's 1 point off of where it should be? What does that mean? I'm dying, that kind of thing. Because that was the concern. I deal with enough messages as it is. Now they're going to get these labs before I have a chance to comment on them potentially. On the positive side for patients, it's actually lit a fire under some of my colleagues that would wait 2 weeks to get some standard labs back to somebody while they're waiting, and it's just kind of your routine to wait until they come back to see you or what have you. It's been relieving to know, okay, that was fine. You may not realize what they're worried about. One of the things I try to do when someone comes in and they just don't seem to be relaxed about the diagnosis, saying, well, what are you concerned that it could be? And I think sometimes when this information is exchanged more freely, that it's allowed patients to understand that they're okay. But I could probably go on. I'll stop there. I'm curious what Gary has seen from a national level, if you don't mind.
Yeah, Gary, I'm kind of curious as to, has the theory that, so to speak, and the proposition, has it come to fruition in a manner that you've anticipated?
Yeah, well, let me just initially say that I've had the opportunity to. I'm currently doing some work for the Office of National Coordinator through Health Tech Solutions in Kentucky and the Urban Institute in DC. Also, I've been working with a few other states, health information exchanges, and issues are very similar across all jurisdictions, right? I mean, nobody has everything working very well. I mean, the way we'd like things to work. So sometimes we get frustrated in Kentucky, or sometimes we think, that our problems are unique, but they're really not. Some states are maybe a little bit ahead of others, but the problems really are universal in terms of specifically interoperability. And I think one lesson we've learned in the last, 19 months or 20 months now is, we all on this panel and probably the attendees have always, understood the importance of interoperability and data liquidity and the ability to exchange data and the potential implications. But I think it sort of is, as Brett was just saying, with sort of the not quite open notes, but releasing labs, a lot of providers are now understanding. A lot of the C-level individuals who maybe were not in, a CIO position, but in another position, are suddenly realizing, hey, there's really a key strategy to this interoperability, and I think we all understand that it's not been, working as smoothly as we would like. I mean, I think in particular, with COVID, the realization of just how fragmented public health is, and the issues of immunization and bidirectional queries and the like. Also, care coordination and how do we bring data to bear for care coordination, social determinants, particularly as we looked at underserved populations who perhaps were not getting vaccinated, or we had data that we really couldn't understand, and also I think fundamentally an understanding that the current evolution of standards is really important, and that we do have a vision forward to solve a lot of the problems we've seen in the last 20 months. So I actually, if there's a bright side or an element of COVID, I think that really is important. It's that sort of realization of how important fluidity is of data, interoperability, and everybody sort of thought of it as buzzwords, or maybe I'll look at it when we go to value-based care, and I've got some capital at risk and risk-sharing models. I think people really have an understanding of the importance in a clinical basis, the importance of getting bidirectional immunizations and the like. So those I think are really and it's been realized. I mean, this is certainly something that the ONC and CMS have understood and have been working on. But I think that it's really come home to the users now, and the clinicians, I believe, have I hope have an understanding of where we're going. And we do have a roadmap, and we could talk a little bit about that roadmap maybe later in the session.
Great. Dr. Wright, how have you seen the interoperability affect your facility and rural health?
That's a great question, Robert. And I think Brett and Gary queued this up, and I appreciate you calling on me because I'm really fired up about this. And let me give, rather than get right into rural health, I think this is, more of an issue about disparity, which I think rural health exemplifies. And I think what we learned with COVID was the isolation of COVID really showed us how to embrace technology. And that technology, I think, that patients utilized was telehealth. But I want to look at telehealth not unto itself, but really about patients utilizing technology and starting to get a glimpse of how we can offer them a different form, maybe a better form, a more expedient form of care. And underlying all of that is data exchange and interoperability. Because when we talk about interoperability, I really look at that more as ubiquity. I think for the last 25 to 30 years, healthcare has chased ubiquity. We want that immediacy, as Dave Bolt said in his introduction, real and timely. I think we want real-time data exchange. We want to know a balance of information. If somebody has something done in Eastern Kentucky one day and they show up in Central Kentucky the next day, we want to make sure we can put that information together. But beyond that, as social determinants of health were referenced, I think it's not just about the clinical exam room data. I think we're seeing now the clinical exam room data has different layers to it, a different arc, if you will, of issues around the social determinants, of issues about the environment, more insight, because data has to be driven to information, be driven to knowledge. And that's what we're all seeking here, because the deluge that Brett mentioned, for years I've said we suffer from data deluge syndrome, because we don't have an absence of data. We have sometimes too much data, but we don't have the clarity of information and knowledge that needs to come from that data. And I think that's what we're chasing. So interoperability, yes, we need it. But I think what we really need is to have that moment that we had during COVID where people understood telemedicine. I think patients really need to understand the importance of data exchange and data migration and interoperability for care, because I think we're just scratching the surface of where healthcare is going. We're just scratching the surface of where we need to go. So I think this is great. Appreciate the comments and look forward to hearing more.
Yeah, and I think as we, the comment about telehealth and the intersection of the HIE and telehealth make natural sense. When you see a provider who knows what you tell them, your symptoms, what could be a better tool to have access to when you're looking at that patient through a screen than the HIE data, right? And to be able to hopefully treat them in a better manner and a more quality outcome because you have that information that may not be told to you as a provider. There's definitely a great opportunity, I think, in the future for the intersection of HIE, EMR, EHRs, and telehealth that many times I think has been overlooked in the past. Dr. Theriault, Medicaid has definitely been had to fulfill interoperability, and I know that it's been a project that KHI has worked on, and also the Office of Application Technology Services to assist in putting all those rules in place. Do you have any thoughts or comments from the perspective of the Medicaid members, or from, so to speak, as a payer, so to speak?
Well, thank you. First, I think it's I think our members, our patients expect this to already happen. They expect us to have this information. I mean, they're used to pulling up their phone and asking Siri a question or asking Alexa and getting an answer right away. And I've had recent conversations with patients, and they think we have this information as providers. And to know that we don't yet, we almost do, it is shocking to them. It has been shocking to them. So I think our patients really want to have access. They really expect us to have access to data from different places, and they don't understand that it hasn't been standardized for a while. Other things, important things are standardized. But I think, or what I've learned recently, that I think Kentucky is in a great place. I think Medicaid in Kentucky working with with KHI is very, puts us a step ahead as far as interoperability. Medicaid is actually takes care of a third of the patients in the state of Kentucky. And so we really kind of see ourselves more as a player, not just a payer, and as a leader in healthcare. And as we accept things and push things forward, we hope that other payers in the state will do the same. So we're very excited about the interoperability. Our Medicaid patients are excited about it, and they expect this to get done.
Hey, Robert, if I could add, I think there's a bit of a paradigm shift too that ONC has driven over the last 6 or 7 years of implementing. We're talking about providers getting data on their patients, and that is, as Dr. Wright can testify, I mean, a clinic doesn't go by that I say to a patient, I didn't get anything from Dr. So-and-so, and the expectation, Dr. Theriault said, is there. But I think that's shifting to put the patient at the center of that. And I don't mean they're responsible for it, but giving them that information. And if they show up and I say, I didn't get anything from Dr. Wright, well, here, let me pull it up on my phone. That's I think ONC's intent. And I think that's a paradigm shift for us to be thinking that way, that, I mean, the patient's been at the center of care, but the center of storage of that information and data has not been their purview, right? And so I think that's shifting, that does affect your strategy for data exchange and how you're going to approach that. Maybe you don't need a certain connection or a certain data feed because the patient's going to bring that more curated to you, meaning not necessarily curated in terms of the data, but associated with their symptoms and other things that make a much bigger difference than us getting raw data from a feed.
As we talked about the patient access rule, thoughts about that, but also at one time we heard a lot of, and actually probably twice we have heard a lot of talk about a personal health record or a PHR, and what are your thoughts about the access rule? Will we see a reinvention of a PHR again type of thing, or do we expect the access rule to cover that? Thoughts first, Gary?
Yeah, sure. That's a great question, Robert. I mean, I think that a key piece. I don't know if I'd call it it'll be called the personal health record, or whether they're going to be called data aggregators, third-party data aggregators. Certainly under the and if you're not familiar with the Cures Act, I mentioned to the attendees, it's worth trying to find a Cliff Notes version of it, just because there's so much in it and so much that it sort of affects health data and individuals. But a key piece of it is a rule that allows third-party application programming interfaces, APIs, into an electronic health record. So if you're an EHR vendor, or, there's really no such thing as an EHR anymore. They're certified health IT products. The ONC did away with the concept of a single EHR with the 2015 certification. But if you're have a certified product that is being used as an EHR, we'll just use the shorthand, it's easiest. Basically, you have to allow third parties to have access to the EHR for the patient record, and you can recover your costs. I mean, you actually have to keep. It's like the old telecommunications business. You can only cost recover any sort of API charges. So it really levels the playing field. I mean, right now, Apple HealthKit is about 99.9% of that market, right? But you do have these third-party APIs where a patient, a consumer, can provide permission to aggregate records and then direct that information, just as Dr. Oliver was saying, to providers, or you can become your own traffic cop in effect. So then the question becomes, how does that relate to traditional, or what we would consider, infrastructure, dedicated health information exchange versus, the sort of API world? And we could talk a little bit about best healthcare interoperability resources, or FHIR, which is the standard that will be supporting these third-party APIs, because it also supports a lot of other type of transactions. So, I mean, I think that, will all consumers do this? Probably you'll have the sort of diffusion curve, right? With some individuals aggregating information and sharing information. But, if you look at the diffusion of cell phones, faster than any other technology, and, this is an app and a lot of cell phone apps. So it's going to be an interesting world. So, yeah, and this, as Dr. Oliver said, this is all really driven by sort of the vision of ONC and Congress and CMS and other entities really trying to drive this interoperability, trying to provide different avenues to get the data where it needs to be.
Dr. Wright. Yes,
yes.
please.
Thanks, Robert. I'm going to, so PHR is dead. Long live PHR. I don't think it's going to be called PHR. I think it's going to be called UHR. I think I see it's more universal. And then I say that, and you look at the market, and Gary said, he mentioned, large company's name there and HealthKit. Think back to when tablets were being reintroduced. Tablets were brought to the market and they failed. That's what everyone said. That's what everyone said. And then timing's everything. I think PHR is going to be very important. I think people understanding that health record. And I think all of these APIs and this development around FHIR is really, you know, as I said in my earlier comments, just be prepared for where healthcare is going. When you start unleashing this data, when you start giving patients freedom, you know, to use their healthcare or seek healthcare in different ways beyond telemedicine. You know, because I'm a believer that health is in everything we do. Health is not just in the exam room. Health is everywhere in society. Health is in the grocery store. You know, when you pick out what you eat, what you do, how you live, you know, all of those things, whether it's social determinants of health or basic, you know, basic practices of living. So this is really exciting and why we have to, you know, dive deeper in this data exchange. I thought we would have had interop in 2005. I came out of medical school in 1998. I thought 2005, they'll have it figured out. Whoever they were, they'll have it figured out. It's amazing to me. We're in 2021 and we're still having these discussions, but we are, and I think we're closer than where we were. And it's a fascinating time. One point though, I do think Gary's point about how the adoption of patients, I think sometimes people who need to be the adopters may not be the adopters because chronic illness being what it is, they may not have the resources, whether cognitive resources or cognitive and financial resources or just insight to pursue. So I think that there's going to be an area here to have navigation services going hand in hand with these PHRs, coordinators, fiduciaries, if you will, to help people work with these apps rather than them just sit there. Because my comment about PHR is dead. If you look at how PHR was brought to the market through Health Vault and Google, they require the patient to do too much. You can't require the patient to do too much here. And you still, healthcare is not going to go away. We're just going to have to align with these tools to make sure we have better patient outcomes.
I think with that, too, if I could just dovetail into what Dr. Wright was saying, I think patient education about their data. I mean, that's not something that we've really talked about with our patients in general, and understanding if I'm going to put that on my phone and this API is calling out, what access does that company have to my data? What are they doing with it? Some are nefarious, some are, lots are not. But I think understanding that it's not protected like it is in our offices or our facilities. I think that's a gap right now, at least in the patients that I see.
Right. Just curious, Dr. Terrio, what benefit do you see to Medicaid members having greater access to their health data? And how would you see that working with Medicaid and some of the MCOs potentially that are associated with Medicaid? I think you're on mute. Sorry. We haven't had a chance to say that the whole session. You win.
No. I'm sorry. I actually see our patients, one benefit is payer-to-payer information. So the connection, if a patient switches from one MCO to another MCO, everything switches. So you don't start over. That's very important. The just with our MCOs better, and I think we're doing a good job of connecting and with dialogue, but just having things more seamless between the different payers.
Yeah, that makes a lot of sense. And I think the comment about it has to be easy, it has to be secure, are all challenges. So I'm going to throw a question out there just from the perspective of your 2 cents, so to speak. When do you think, or how long do you think it will take for us to get to the point where not only is the technology in place, but the privacy and security are built in, and the way we want to use these apps as an individual to know about our health especially from a clinical perspective. What do you think is the time frame regarding that?
I think that I can provide some information. I've been working to help develop reporting requirements under the Electronic Health Record Reporting Program that was mandated by Cures. I have to be careful what I talk about. Anything I'm saying is in the public record. They're currently in a public comment period on these rules. So I'll just basically share the thinking that in order to be certified, developers of certified health IT products, it's not clear how many, but the largest for sure, will be required to report on their performance. And that timeline they're looking at is 2024, 2025. So it's not saying you have to be able to do this. You can report you can't do it, but you'll so that is sort of the timeline that is roughly being used or sort of considered relative to new rules for reporting on your capability. And, some proposed measures, and these proposed measures are all out for comment now, but I can just sort of describe them, are things like third-party APIs, how many you have, what's the traffic like, clinician-facing APIs or FHIR-based APIs, that is clinician-to-clinician transactions, so that you're sort of moving away from, you're using FHIR instead of the sort of classic consolidated clinical document architecture standards. You're moving toward, an internet-based system, API-based system, as opposed to something that's, certainly clunkier than everybody anticipated. So, though, and the idea is they'll, potentially have to, and this isn't a proposed measures open for public comment, bi-directional exchange of immunizations. How are you performing in your ability to do that? So you'll at least get benchmarks, and maybe you nudge the market in the proper direction. So I think the expectation really is in 3 to 4 years, much of this infrastructure is going to be being used. So that's just the timeline.
Great. So we had a question, and Dr. Oliver provided his comment. We had a question from the audience regarding thoughts about community health workers assisting in the education and training of residents and citizens in using those tools from the perspective of their electronic health information. Any thoughts? We see that Dr. Oliver thinks it's a great idea. Dr. Theriault, any thoughts?
I do think it's a great idea. We're starting to use community health workers more and more with our Medicaid population, not only to teach about diseases, but health literacy and how to use the whole system. And this just falls right into that. And I think it's really what's going to happen in the future.
So let's move a little bit. Thank you very much. Let's move a little bit to thinking about what type of policy changes may have to happen in your organization, any forms of governance that you would like to contribute regarding the recent federal policies and the implementation of those, and what that means to your organization. And then we will switch gears to kind of a different subject. So any thoughts about policy, governance, considerations in a healthcare organization going forward? Dr. Wright, would you like to comment?
Yeah, I'll try to give brief comments on this. I think I'm in preparing for this, I made some comments with the group that, I still think we have issues with people in local governance setting. I'm talking about local governance. I'm talking about your directors, your coordinators within the hospitals, really understand how data moves fluidly, and how clinicians need to have data at their hands. And, I see a lot of fights take place. Yeah, I said fights, spats, if you will, about somebody wants to do it one way and they really don't understand the clinical workflow or what it is to manage a patient in the room. And, physicians are getting, fed up with inefficient workflows. I think there's a real issue with administrative burden in healthcare. And I think that, those individuals on a local governance, I'll let others talk about maybe a higher order of governance, but we still got to get local governance, because to me, that's the last mile of this. You can get the feds to get it right, but if you don't get it implemented in the local centers, well, you're not going to get efficiency that you want in patient care.
Dr. Oliver, additional comments?
No, I think Dr. Wright is spot on. That's one of the reasons that I applied for the federal high-tech committee position. When I looked at who had been appointed to that point, half of us are appointed, half go through a process. No one was seeing patients. Now, fortunately, there's 3 or 4 of us that were on there, and it just made me mad. It was like, my goodness, we're making all these rules and what's going to happen, and there's no one who's actually caring for a patient there. And so, while I certainly am not the IT expert or even policy expert that Gary is by any stretch, hopefully that's what I've brought to that committee, because it's so key. I think, within our organization, our governance is strong. I think where we lack, though, both in a governance from a public perspective as well as within organizations, is communication. And in healthcare, we have let the government decide things for us without our input. We just haven't advocated well for ourselves. I think attorneys do a great job of advocating for themselves. We're taking care of patients, our heads are down, and then all of a sudden we look up and we've got an info blocking rule that's ready to go in a week. I had 3 or 4 physicians in my organization reach out impassioned the week that we were going live with sharing of notes and labs and say, this is terrible. Who made this decision? And like, oh, I would have loved your passion 7 or 8 years ago when Congress was debating this, because here's where we are. And so, it's advocate, because I feel like, and Robert, you've been witness to this too, like on the state telehealth board, we're listened to when you explain a workflow that's just not going to work, or it's going to add incredible burden. No one that's making that decision wants to add to the clinician's burden. I've not met them yet. They don't realize it. And so if you can bring that to their attention, I think that really helps. The example with telehealth was the ambulance code. The Medicaid wanted an ambulance code coded in this is before the pandemic. And does our EHR support an ambulance code? What is an ambulance code? I've never coded an ambulance code, and they wanted that data. And so I get that, but in gathering that data, it shouldn't be on the backs of the providers, because to Dr. Wright's initial point, we touched on it as a group. We can't just provide data. We celebrate the fact that we're exchanging data, and that's wonderful, but it's got to be actionable. It's got to provide clinical insights to the end user, whether that's a physician, a case manager, a social worker. It has to be actionable. If it's not, we're wasting time. We're just causing white noise that's going to be ignored.
Dr. Terrio.
I would just like to add, as a practicing provider, that is so important. If sometimes on a Friday afternoon after a long week, when somebody says, oh, you just have to do this one little click, and then you get to here, it's like, I'm not doing it. I can't do it. I can't do one more click. And our clinicians don't they say, oh, they're silly doctors. They can't just do one more click. But you don't understand that everybody brings you your one more click. And so then to do anything, you have to do a whole lot of clicks. And so physicians really need to be part of that workflow. The care coordinators really need to tell us, what works best for them. Everybody with on the front lines of patient care really has to do that, because you can make some wonderful program that will connect data. I mean, it will be the best thing in the world, but if it's not easy, no one's going to use it. So that's so important to get input from your providers.
Dr. Zanuck, you're a little outnumbered here. And I see you're nodding your head in agreement.
Yeah.
So
I have a follow-up on Dr. Terrio's actually, because I would like to actually come to the defense of some of the leadership in healthcare organizations. I mean, they've been oversold. I don't think there is anything more oversold than interoperability and electronic health records and And, I understand when they don't want to do that one extra click, right? I mean, they've been told it's how many times? It's just one more click, one more click, one more click. So I agree with all of these problems, but I still think there's a fundamental issue that the vendors and the standards and basically the infrastructure has to make it easier than it is, and then governance becomes easier once you're showing you're solving problems. I mean, I don't know a single provider who does not like. We have somebody making a comment now. Workflow, safety, data. But the problem is it's been made too difficult. Separate sign-on at the same time. The providers, the number of patients they have to see has increased so dramatically, not being reimbursed for email, not being reimbursed, well, just until recently for telehealth. You're putting a lot of pressure, and I can understand, frankly, the pushback and the burnout on the technology. And I think some of us are at fault in that, as Dr. Wright said, he came out of med school in '98 and thought everything was going to be solved by 2003. And so, I mean, we have to have better solutions. 2005, sorry. I do think, though, that I'm a real believer that using a application programming interface solution like the internet uses, FHIR in particular, which is the standard, that's FHIR, and linking that to the USCDI core data elements that have been identified, it's going to make it much easier to exchange data and integrate it and make workflow better. And then I think then it's easier to deal with once you have proof that it's not something you're overselling again. Then I think it's better. So I just want to get in my soapbox.
Great.
Can I add something in, Robert?
Sure.
I want to highlight the work of KHI and what Andrew and his staff did. We brought them in to our clinic when they were doing some fact finding for some development within KHI. And they sat down with a team of doctors and talked through workflow. And we tried to educate them on what we term the clinical minute. And that's that time when you're sitting in front of a patient, the patient's leaned over their chairs, they're waiting for what you have to say. I mean, this is their life. Okay, it may be your clinic, but it's their life, and they're leaning in, and you're looking at that computer screen, shaking your head in your mind. Where's this data? Where is it? Or I'm having to click, or I hit a login. All of those things, all of those efficiency all those matter, and I just wanted to applaud KHI for really digging in, because I think that meets both sides. Gary, to your point, I mean, everyone's trying to do the best work. Nobody's trying to hurt anyone here, but you really have to understand culturally what it's like in healthcare when you're trying to provide care, when you're trying to get patients in and take care of them efficiently. Because workflow, if you want to think at it from the system standpoint, workflow is cash flow. And if you don't have good workflow, you don't have good throughput. And, maybe shame on me if I mentioned money on this talk, but, you have to look at the economics of this. And if you don't do things efficiently, you can't run the organizations that we're all a part of.
I think one of the greatest compliments that I've heard about KHI, and thank you, Dr. Wright, for that compliment regarding our discussions and investigation regarding real workflow, was when Dr. Terrio said the other day that she was in her EHR at a healthcare facility and had no idea that literally she was seeing KHI data embedded in her EHR as she was looking at a patient's record, that it wasn't just necessarily data from that particular facility or relationship to that facility, but it was literally KHI data across, from their record across the state. So, I think that's a great compliment, because that's what we want, right? That's when it gets used, is when people are unconsciously, or so to speak, being given the information they need to use at that point of care. So there's a comment that I would like to mention from Dr. Farlisi about federal activity and funding for public health IT workforce training that you may choose to look at in the Q&A, and a link there that she has made available to you. Interesting comment also in here is as we've have been addressing in Kentucky, in particular the opioid epidemic, and with multiple programs and looking at behavioral health, and that along with COVID has probably brought behavioral health to the surface, where we've kind of traditionally always said physical health, behavioral health, right? And so let's talk a little bit about behavioral health, data exchange, interoperability going forward. What do you all see as the future when it comes to that interoperability of information there? Or what do you see as the need that you would hope would be the future going forward, as it's extremely important? We've seen obviously telehealth open up to behavioral health treatment going forward, so I'd like some thoughts, comments regarding that. So I'll just open the floor to whoever would like to speak.
Robert, let me speak to that. And I may not be answering your question directly, but I want to share something that I've learned from the market. I'm subscribed to a weekly newsletter, and this is something that was brought to my attention that's astounding. It's astounding. There are 1,000 behavioral health startups in the world. So what that tells me is the consultants, the market, the venture capitalists all understand that we're in a global mental health crisis, and that we don't have the luxury of just training these people and creating them, within a matter of months. These individuals are created over years. And there's going to have to be a way to democratize or scale mental health. And mental health is going into these apps. You all are familiar with some that are out there. They advertise quite frequently, but 1,000 startups. When I heard that got me to start thinking about, the nature of this, and then looking at the mental health here locally. We've always been in a mental health desert in rural areas. We've always had that. So I'm looking at this, anything to help our patients. So to your question, absolutely, we're going to have to find a way to bring this information in that is occurring, whether it's an API or otherwise, so that clinicians can help utilize this. And we've got to get beyond saying, hey, we'll get you in with this psychiatrist in 6 months, because that patient may not have 6 months. It may not have, and we're going to have to make proper use of these tools to really benefit people.
I would just like to add, can you just share the information from within my organization with me? When you're talking behavioral health notes, they're so walled off. I can see what medication you take, so I can kind of suppose a diagnosis, but it'd be really helpful. And I don't need your life story. I don't have time to read your life story, but understanding who you're seeing and who you're plugged into within my own organization would be wonderful. But there's, that's a legislative piece of work that needs to happen. And what Dr. Wright said, I think, goes beyond behavioral health. You've got all these apps out there. They're not vetted, at least the ones that are non-FDA approved to be prescribed. They're not vetted. So how do we vet them for our patients? If there's 30 different ones about monitoring my blood sugar and make suggestions on how my care can be delivered, how do I know as a provider? What do I tell them? I know as our organization, I would love to provide a pool of curated apps for our providers, so at least they know in the heat of battle, okay, this is good for this is good. It's someone at my organization has looked at it, but from an app there. To Dr. Wright's point as well, what was it, $20 billion last year alone, and they've already exceeded that in venture capital investment in digital space the first quarter or this last quarter. It's crazy the amount of money, and people want that money back. There's going to be a lot of pressure to make that happen, and that concerns me that there isn't a plan for the data sharing with these silos of care, and behavioral health is one that's already siloed enough.
Right.
I would ditto that as a primary care provider, that when patients come out of the hospital, a lot of times they come to us, and if it's a behavioral health admission, we don't have the data. We don't know when they're supposed to come back. Patients don't know what medicines. It's crazy. And so in order to help coordinate the care for our patients, we really need to know that. But, you know, telehealth has done so much for behavioral health, trying to reach into the rural areas. And I see that, you know, nobody really used telehealth before, even though we had great laws and parity for telehealth before the pandemic. Everybody was pushed into it against their will. We had big spike, everybody's using it. And now it's dwindling back down, but the people that are continuing to use are behavioral health providers. And it's a great use of telehealth is to get the behavioral health provider to the rural areas to help people. And so I kind of see, looking to the future, that telemedicine is really going to be in the forefront for behavioral health, you know, now and years to come. But we do need that connection with the mental or with the physical health folks so we can help our patients.
Any comments, Dr. Zanuck, on discussions you've been made aware of or roadmaps relative to what we're talking about?
No, I mean, I'll just point out that, you know, who does HIPAA apply to, right? I mean, your traditional providers got to work under 42 CFR Part 2, which, you know, severely limits the exchange of information that's, you know, mental health, behavioral health related, or you know, HIV related, or and the like. So, but by the same token, your third-party apps we were talking about, some of them don't even have privacy policies. I mean, we think most of them do, but you know, do they even have a privacy policy, and who are you signing this off to? And then, you know, it's a tremendous amount of challenge, you know, as behavioral health, you know, you know, how do you get to the behavioral health provider? I did an analysis for a state. It was in another project, and we calculated, it was a state in the Northeast. There are actually 12 different types of behavioral health providers in that state. You know, we talk about behavioral health like it's a monolith, right? But I mean, there's just so many different types of behavioral health care that I think it's important to break that down. And then finally, just mention the issue of unstructured data. Because so much of the behavioral health data is unstructured data, that is, you know, notes. How do you deal with unstructured data? How do you exchange it, and the like? But I mean, I just think that the issue of privacy policies is certainly with these sort of third-party health apps is a key, is a big question right now. So.
Okay, so let's go around and talk about what you see as one of the greatest opportunities post-pandemic as we look forward from a state and local level. And so where do you see the greatest opportunities for health IT going forward to assist with the care and better outcomes for patients? And if you'd like to comment as to how you feel the pandemic may have helped shape your opinion on what those things will be, or maybe it hasn't and you're just ready to get past that. But let's talk about that, and we'll start with Dr. Wright. If you'd like to just talk about what you think, or maybe the top one or two opportunities you see from a state and local level as it relates to health IT improving care and outcomes.
Yeah, thank you for that, Robert. I think we have to rely on the ingenuity of Kentucky. And often you don't have that said, but you look at the successes Kentucky has had. You go back to Casper. You know, Casper was a great system. You know, Kentucky really did something right. You look at telehealth, look at that legislation, what we've done. I mean, when we go to the AMA meetings, we're far ahead of so many of these other states. I mean, they're looking at Kentucky because we really got things right. And I think now, I mean, if you go from those two, if you look at that wave or you look at that trajectory, let's get health information exchange right. We've got good coordination all around. We've got, I think, everyone around the state, you know, we work together. I mean, we're usual suspects to one another. We show up at the conferences. We end up on the Zoom meetings together. We've got, you know, great expertise. We've got Gary. We've got other individuals who are out there on a federal level, Brett, his service. We've got Andrew, who's always, and you, Robert, who's always eager to engage. And I think we need to take the information we learned today. Look, it's going to third-party apps. It's going to apps. I mean, that's where the money is, and that's where it's going to be driven. And why not control that in Kentucky? Why not control some of that innovation in our own area? Why not have, whether it's, the cabinet do hackathons or anything that's permissible, to get people to start thinking about this. And maybe people in Kentucky, maybe Kentucky residents need to start thinking about data as, instead of KHI as something that exists in this big building in Frankfurt, maybe it needs to be my KHI. Maybe it needs to be more personal. And I think we have the opportunity as we see the apps moving. And I think just our tenacity as Kentuckians to get something done and get something done well when we want to, I think that's our real opportunity. That'll make a difference in patients' lives.
Yeah, some great, innovative, creative ideas. Dr. Oliver, thoughts?
I think the opportunities in the public health data sphere are tremendous. I think everyone on this panel, maybe everyone that's listening now, knew that there was a problem with public health data. I mean, there's probably a whole talk on how we got into the mess and how things are prescribed in a public health setting, but the pandemic really just opened that can of worms. Said we've got to do something, whether it's through funding, looking instead of these little silos of data. Oh, please send your immunizations over here. Oh, please send your communicable disease information here. And then it also exposed this infrastructure in public health that's so dated. Quick story. So the CDC comes out and says, we'd like you to report your COVID cases electronically, electronic case reporting. Fantastic. We would love to do that because it takes 30 to 45 minutes per patient on the data we have to enter. Quick project. We throw it together in 6 to 8 weeks. We're ready to go, only to find out the infrastructure isn't there to accept the data. Oh my gosh, that's maddening. And it undermines the confidence that you have in the public health sphere. And so, I think that's a real opportunity to beef up these infrastructures, make them the state of the art. Why should public health not have state of the art infrastructure in place? Lead the way there. And it's always seems like the private sector that's dragging the public sector's infrastructure away. So that at a macro level, I think we really need to continue to push in that regard. I think the other opportunity post-pandemic, if that's even going to ever be a word, but is this digital experience for a patient, the user experience. The floor for that has been raised tremendously. Rather than, oh, I've got a portal for my patients to get their labs. Now it's their center of care. It's how they log on for a video visit. It's how they exchange information. It's where they have their proof of vaccination. If you're not strategizing that already, you're behind. And because I think that is just going to become the core of how we deliver care, whether you're seeing Dr. Wright, you're seeing Dr. Thoreau, you're seeing me, you're seeing a social worker. It's all going to be centered around the patient, as it should be.
Yeah, great comments. Both KHI and our Health and Human Services Analytics have been strongly supported by the Kentucky Department for Public Health from a financial perspective, with appropriate funding, and with supporting the integration. As you said, these silos exist. They're going to take time from a transactional application perspective to replace. That doesn't necessarily happen overnight, but that data can be dropped into the lake, normalized, integrated with other data, so you can do true population health when you look at a lot of the public health records integrated with whether it's Medicaid claims and encounters or clinical visits, et cetera. And so that is very much a vision of our department in supporting the cabinet's core businesses like Medicaid and public health and behavioral health and going forward. And we've seen great support from our own public health department here in a very tangible way. So we're grateful for that. Dr. Terrio, thoughts about the future?
I think Kentucky is really set up in the right way to be a leader for the future. When just the fact that KHI is part of state government, and that you are able to work with the public health folks and behavioral health folks, everyone's in that same big building, and listen to the experts from the different fields. This is incredible. Other states don't have that. And so I think we can build on what we have and then move forward with the little things, you know, the tweakings to making the public health reporting more seamless, to going with apps and investigating apps for our patients to use. Again, Medicaid, a third of the people in the state are on Medicaid. So we need to move forward and continue to move forward to do all of these things. But I think we're really in a good place. And I know we're not supposed to be competitive with other states. The doctors are very competitive. And we are. Kentucky is leading the nation. So I'm excited about that.
Awesome. Gary, any closing thoughts
Quickly, I
about
guess.
post-pandemic,
Sure.
going forward, opportunities?
Echo what Dr. Oliver said about public health. That is obviously very important, and also what the general observation that Kentucky really has an advantage in that KHI and the policymaking is so closely integrated. Most other states really have a third-party health information exchange. Very few are even integrated with their Medicaid department to be able to be eligible for federal funding under MMIS and other programs. So that's a real opportunity. And then finally, just in the big picture, I think there's real opportunity to solving the interoperability and combining FHIR, that's once again FHIR, which is the API-based standard adopted by HL7 Smart on FHIR, combined with the US Core or USCDI elements. So if our attendees, if you're not sort of familiar with the standard side, if you want to look up USCDI and look at FHIR, I think it'll be quite useful for you to see how it all fits together in terms of federal policy. So with that, I'll stop.
Great. There is a question regarding social determinants of health being addressed. I believe that is our next session where we will dive into the relationship between KHI, which will have in its portal and available for integration into EMR EHRs, the standard defines social determinants, and those social determinants will be used with connectors in providing those local resources for those social determinants. Obviously, as practitioners, you guys have the capability of diagnosis codes, link codes, et cetera, to indicate what you see. But I think you're going to be impressed with the interoperability, again, of what you see happening and the cabinet working across department lines, so to speak, to keep common definitions in place. Why invent social determinants in KHI? Why look at social determinants in child welfare? Why look at them in connectors when they can be the same and contribute to each other, right? And end up with the same result, which is assisting the patient in meeting their need. So I'm going to open the floor for the last 2 minutes for any closing comments that you may have. And then we'll move into that next session. Quiet group now. So I get to thank you for being here, very much so. We thank you for your time, for offering your expertise. I think the experience that this group brings is just invaluable. The mix of the panel is just, you know, that's just, to me, that's when you get the best of both worlds, even if Gary is outnumbered. But that's okay. He's a tough guy. But no, really, I do appreciate everyone's time on here and appreciate the comments. The forward thinking, the creative thinking, and the practical side of this that really is probably going to be the future going forward, and how do we get there sooner than later, so to speak, for the benefit of the patient. So again, thank you, and I will assume we are going to end this session now, as we are exactly like 1 minute to finish up. So again, thank you all very much.
Thanks, Robert.
Thank you.
Thank you.
I guess we're done.
I think we're out. Good seeing you, Brett. You doing well?
Yeah, how about you?
Same, just one day at a time.
Yes, sir. Yes, sir. I like to get these numbers down.
That's right. That's right.
Take care. Let me know if I can help.
All right, I will do. Thanks.